lecture, and was the idea of activation versus non-activation. So there's a lot that goes into the thought process for PRP. I guess I can start my video here. Sorry. There's a lot that goes into the thought process around PRP thickening agents along with activation. But I would say that PRF is a little bit of a blinding science that a lot of estheticians are being sold on right now. One of the other things I'd make mention of, I don't know who's left on this call, but a lot of the systems that are out there, Mayo Clinic did a study, I don't know how many years ago, but it was recent. Mayo Clinic did a study where they actually analyzed all the systems in terms of what actually meets the definition of PRP. They analyzed 33 systems. The RegenLab system was actually one of the systems that came out as having a final PRP product that is actually less than baseline. So of the 33 systems that they analyzed, 3 of them don't even had a concentration level that was less than whole blood. RegenLabs was one of them. And there were a number of other systems that did not meet the requirements. Frank, you also made mention of whether or not platelet recovery is like well-defined. And there was a study done by a French guy named Mogadon where they actually defined platelet recovery via statistical analysis. So when you get into the science of PRP, it's really interesting. And unfortunately, or fortunately, it's all I do. So it's pretty good.
Yeah, Nathan, that's an excellent point about that. And I did not want to get into that because, again, that would be throwing in my numbers as opposed to comparing them to the company numbers. And again, I just started recording the video because I thought it was good stuff. But you know, the hematology analyzer that I have, I was, you know, gel tubes in general, because the RegenLab does not have a magic gel. Like, they just don't. In the same way that Harvest does not have a plastic cup, in the same way that Arthrex does not have a magic centrifuge. It's all basic hematology. My hematology analyzer was taking gel tubes and analyzing them, and I was routinely getting 0.7 times. I only once got a 1.6 times concentration from a gel tube, and whether that's RegenLab or one of their competitor gel tubes. So that's the beauty of having a hematology analyzer, is you know what you're putting in your patient, and if the result is suboptimal, then you can consider the what you put in as one of the variables.
Yeah, and one of the things you also made mention of a lot of was total platelet dose. The science is going towards what is the appropriate platelet dose for a certain degree of injury versus, you know, a joint injury of severe or moderately severe arthritis versus mild arthritis. We're going to have to start quantifying that. We're going to have to raise a standard in terms of our own platelet counting. The danger that we have right now is that a lot of people are jumping on the bandwagon, but they're not really playing into the science in a very specific manner. And that's because we have, you know, you have salespeople and you want to be able to offer a lot of things and all that. But, you know, the reason why this course is so important is because it allows us to get into appropriate identification of ultrasound, followed by, or of anatomical locations, followed by diagnostic scanning. And diagnostic scanning is where you're going to make a decision as to whether or not PRP is actually viable for that type of injury. So I would be, you know, I think a lot of people should do it, but we should also be cautious in patient selection. And as Frank said, conservative in that approach. You have to be pretty certain if you're going to sign up to somebody for a $1,000 PRP product. And you also need to know the protocols and the sequences that set people up for success. And those protocols and sequences are not necessarily obvious unless you pour through the literature.
And we've got Mark and Patrick on the call, and I wanted to ask either Mark or Patrick in either order. Mark, if you're by your device still, or maybe you've gone out to play basketball, are you using PRP of any type in your teaching at U of T Sport Med Fellowship? And then Patrick, if you're on the line still, are you able to share any of your experiences? Because you probably would have given this presentation better than I. So I'd love to hear your thoughts on what you've learned using a hematology analyzer.
Is this Patrick Ma that we're about to speak to?
Well, I think Patrick, it's to my knowledge, is Patrick Yam in Vancouver.
Oh, Patrick Yam, sorry. Oh yes, okay, wonderful. I hope he's here.
Frank, it's Mark here. Um, I'm relatively new to PRP on my own, but in terms of how we are teaching it in the program, it's sort of a work in progress, to be honest. I think it's one of those enrichment topics for the fellows, and obviously the interest is increasing. So certainly I'm participating in this as sort of an individual who's kind of coming into it from like probably being maybe at most at the level of my fellows and sort of trying to learn backwards. So I guess that's where it is right now.
Well, I think that's good. I mean, you saw the number of variables, whereas with cortisone or HA, there's fewer variables. So I think your approach is sound. Patrick, any thoughts? Oh, Patrick just put in the chat that he's trying to get his mic going. Anyway, if you can't get your mic going later, just shoot me a selfie video and send me your thoughts, Patrick, and maybe we can even schedule a time later where we can have you on as a guest. I'd love to learn from your experience. Dr. Abelaran, are you doing anything are you doing much with PRP yet at your clinic? And then who else? Philip out in Vernon. Are you doing much out there, buddy?
Well, I'm aware of PRP, but I've not done the injection myself yet.
Well, that'll change come Monday morning, I think, huh?
That's the whole idea.
See you this weekend, buddy.
Thank you very much.
Yeah, I haven't done very much PRP at all, really.
It's good fun. It's a nice variable, especially when people ask about it. It's a nice thing to be able to offer them, Philip. So if you guys can have it in your clinic and offer it there, you know.
Oh, well, I'm blessed. I mean, we have an Angel machine in the office. So there's other people using it, but yeah, I haven't personally used it much.
Okay. And Patrick, I saw your camera come on there briefly, fleetingly.
Can you hear me?
Yes, I can hear you, Patrick.
Okay. That's a great presentation, Frank. And it is interesting to see a lot of new companies coming onto the PRP space, but a lot of them are just kind of copying existing technology. I mean, overall, it's not complicated. You have a gel tube or you have a more complicated separation system. But what I find using a hematology analyzer is that the gel tubes, if you process them according to the manufacturer's instructions, you're not going to get anywhere near what they claim. You're not going to get 2 times. You're lucky if you get 1.6, 1.7, and often you're going to go down. They give a really nice clean product, so no red cells, no white cells, which is great, nice and pure. But the overall dose, unless you draw a ton of blood, is not going to be a lot of platelets. And I don't know if you want that for joints, but you probably have more to say about that, I guess.
Well, that's nice commentary. Thank you.
I have a question, Frank.
Oh yes, Dr. Serene Khanna, what's up?
I saw, I don't know if you mentioned this, I don't think you did, but I saw I think it was Trent talking about a thrombinator along with PRP to induce a clot. I was just wondering why one would do that and what the benefit of that would be.
Yeah, so again, there's so many variations here. So essentially, I'll get away from the use of the word thrombinator and simply say, do you want to chemically or physically activate? And Patrick, think about if you have any comment on what I'm about to say. But is there any way you want to chemically or physically agitate the PRP further prior to putting it inside the patient? And I think there's so many variables here, and the science is definitely not clear. And when the science is not clear, that means everything is game. My personal approach is this. Less is more. I don't want to put more chemicals into my PRP before injecting in the patient unless it's been shown that activating it inside the tube chemically with calcium chloride is massively superior in almost every case, or massively superior in certain cases. And I don't think that's been seen. And then the second thing is, a lot of times I think the manual processing of our PRP is actually activating it before it gets in the patient anyways. And that's not necessarily ideal. Do you have any thoughts on that, Patrick?
Yeah, I agree. There's if you activate it, there's not a lot of evidence that it's going to work better. There is activation, of course, as soon as it kind of enters the tissue, it's going to be activated. Maybe not as much. You might get 100% activation if you added a bit of calcium chloride, whereas if it goes in the tissue, it's going to be activated to maybe 70, 80%. I forget where I heard that, but it still gets activated. I did see one study where they looked at activated versus non-activated for hair, but I don't think you can draw any conclusions because the systems were different. So the activated PRP was not done with the same system as the unactivated PRP.
And I'll just point out something real quick. The level of this conversation is fantastic. And a really, really good forum to learn more about this is the AAOM, the American Academy of Orthopedic Medicine. I'm on the board of directors, and we've got our annual meeting coming up in Clearwater in May. The other place is TOBI, the Orthobiologic Institute, TOBI, and Nathan's been going to their conferences for years, and I went to one. There's tons of people talking about this stuff, and nobody has the answers yet. But I'm loving that people are interested.
What was the final question?
I got a question, Nathan and Frank and Patrick and everyone. So if you guys are using the harvest system and you're looking to treat OA of the knee, say, and the amount of yellow PRP that you get at the end of the second spin is only a couple of millimeters, like it's really small volume. Do you just throw those 3 cc's in the joint and call it a day? Or do you expand it with saline? You can't really use local anesthetic because of the properties of that. Do you mix it with leukocyte poor PRP to create a bigger volume? How do you guys do it?
So Andy, to rephrase the question, which system are you using? You talking a harvest PRP or a
Harvest?
Harvest. Okay, so there's a 30 mil system and a 60 mil system. So what you're talking about, I think, is valid for the 30 mil. It's an important question for the 30 mil draw where you just don't have that much stuff. And I think probably an easy answer is a 30 mil is great for an ankle or an elbow.
Right.
Whereas if you get a 60, you're going to get more. Thoughts, Nathan or Patrick?
So that is the typical answer, is that for a joint, for a larger joint, I would need a larger blood draw to capture more platelets. In cases where if you do have a platelet counter and you know your platelet concentration is high and you're trying to get to a total therapeutic dose, of which I'll point out the total therapeutic dose for a knee joint and all that stuff isn't actually spelled out very well at this point. If you have a very highly concentrated product, let's say you're using an Arthrex product, you very well may have to dilute, but having that platelet counter is what sort of makes the difference. So I would probably say for large joint, you need to use a 60 mil tube with harvest. And if you're using something that concentrates more, then you're going to have to dilute possibly to get to, 5 to 7 times platelet concentration that hits a certain therapeutic dose. Patrick, I'd be very curious to hear what you have to say, given that you process everything via your platelet concentrator or your platelet counter.
Caveat, I don't do a lot of joints yet, but when you consider the concentration, you want to also consider the volume because that determines your dose. So for example, when we do hair, I'm after 3 to 6 billion platelets. So I know that I usually inject that in about 6 cc's. So I need a minimum of 500,000 platelets per microliter. The calculation is pretty simple. If you have 1 million platelets per microliter and 1 ml, then that will give you 1 billion platelets. So if I have a higher concentration, then I might dilute it out if I want to get to that 6 mils. And if I have a lower concentration, then maybe I need to draw more blood from the patient. So there's just more platelets, more ingredients to work with.
So, and Andy, another way to answer the question, I think, would be, I don't usually want to dilute anything down. What I want to happen is I want the platelets to go in, bounce off stuff. I want the platelets to reside in there. And so I don't really want to dilute it down. Like with hyaluronic acid, it'd be great to have a 9 milliliter hyaluronic acid product. But I just want a bunch of platelets going and bounce around.
Related question. Do you guys all take a CBC from your patients prior to their first PRP?
Can I answer that?
I don't.
Was that Patrick?
Yeah, go ahead, Nathan.
So I have a slight, like Patrick, because you're doing, you have a strong aesthetics practice as well. If I could call it aesthetics, regenerative aesthetics. When it comes to sports medicine, I find it's very important to see patients first in a consultative process, because the indications for PRP need to really be reviewed with patients. And you also really need to assess whether or not like they're the right candidate. Are they prepared? Do they have a post PRP protocol? There's so many factors that go into people when you're dealing with discomfort and pain, as opposed to skin rejuvenation, hair rejuvenation. I mean, even for practical purposes, when it comes to, let's say, a biceps tendon insertion, you have to be fairly confident that you can see the problem and be able to hit the spot. And without being able to assess them and confirm the diagnosis, et cetera, you would end up in a lot of, I think, difficult or unsatisfied patients if you weren't doing a pre-assessment and giving the patient a very significant amount of education on what to expect post-injection, including pain reactions into tendons, and also the recovery phase. Patient selection for platelet-rich plasma is very important. And I would tell you, of all the patients that we consult for PRP, we probably only proceed with half of them.
So to answer your question directly, Andy, no, I don't, because I can only, meaning there's nothing in the CBC that will either send them away or rule them in. They bring in whatever they bring in their arm, and then I can only give them what I can give them. And so, but it is nice to have a hematology analyzer, and I can concentrate it to whatever concentration I want.
But you
Patrick?
would, sorry.
But
Oh, was the question, do you do a CBC on them before, or you see them before?
CBC.
Oh, I'm so sorry. I heard C.
Okay.
I'm so sorry.
I found your answer really helpful. I don't do a CBC because I find almost everyone that we treat will have right around 200. There might be younger people with 260, 280, maybe over 300, and sometimes we go below 160. But like Frank said, we work with what we have. So if the patient's really low, we might just draw more blood.
Mhm. I've just had a couple of requests lately for patients who have a history of ITP. And I'm like, well, no, I'm not going to do that without a CBC. But it got me thinking about the fact, well, maybe I should be thinking about this more broadly. But I honestly haven't been doing that.
yeah, so again, the way I think about it is we're trying to concentrate their existing stuff. And so if they've got 80, and we triple their 80, we're up to 240, which is better than they had for healing their hamstring the first time around. Awesome. Well, I'm happy to hang out, but if we're going to hang out, I think we should ask Garrett and Sheila and Nolan and James and Chris some questions as well. So Garrett or Sheila or Nolan, James or Chris, have you got any questions for us? Because otherwise we could stay here all day. I love listening to myself talk, but we all know that by now.
Nothing in particular. I was just listening in, and it's a good conversation.
Okay.
Actually, I have a
glad you say-
question.
Sorry,
I
who is
have a
that?
question. I
Oh,
have
Sheila,
a
yeah.
question.
Yeah.
Yeah. I have this case. Uh, just so you know, Frank, I'm back in the Philippines and I'm back to my practice and I'm starting MSK in my little community here.
Okay.
And it's really doing a great, I guess I'm doing a great job. I had a lot of patients, but here's one patient who came in and asking about, because there's this another guy who's doing prolotherapy and whatnot in another clinic. She just had a blood transfusion. Is it okay to do a PRP on a patient who just had blood transfusion?
I've never been asked that question before, but I would simply answer it from a basic science standpoint and say, if the platelets are good enough to exist in the patient's body, no reason you can't concentrate them in another body part. Patrick, any thoughts?
I would agree with that.
Because you'll also drawing RBC with it, right?
Yeah, I think it'd be fine in the same way that if a much more common question I would say would be somebody would say my patient is on if my patient has rheumatoid arthritis and they're on methotrexate or they're on something like that and it's okay to do PRP. We say sure, maybe the response will be suppressed, but I don't think your head's going to explode.
Yeah.
If the concern is that they've had a blood transfusion and they need those RBCs, with PRP, you're not taking that much, at the most, maybe 50, 60 mLs of whole blood volume. And then as far as the platelets, if there's a mixture of platelets, there's been studies where they've done a comparison of autologous versus homologous collection of platelets. And the homologous collection of platelets from multiple donors seem to have a more of a beneficial effect on, say, hair, for example. So that's a positive.
I'm assuming that study wasn't done in Canada or America.
I don't know. I can't remember.
Okay, got it. Thank you, guys.
Best of luck out there. Enjoy the weather. We got snow on the ground here.
I just want to get a screenshot and send it to you once Canada hits below 0.
Nolan, any questions? Have you set up with PRP in your office yet? Or Garrett, I just saw you unmute yourself.
Yeah, hey Frank, thanks for having me tonight. No questions on the PRP front for me tonight. I've trained with Alex Del Duca and Trent for the last little bit, so they've filled me in on the majority of the details, but loved what you had to present today. It was a really great discussion, and thanks to everyone else who chimed in and added your guys' 10 cents. It was awesome.
Awesome. Thanks, buddy.
Yeah.
Nolan, you got a quarter to contribute? Everyone else is throwing in their 10 cents.
Me. Yeah. I just had a couple quick ones for you. Just curious, do you guys have like a good source where you go to for your post PRP instructions and stuff? Like there's a lot of variability I've seen in different clinics as far as, so some guys will do PRP to an Achilles and basically just say, take it easy for a few days. And then the other extreme is like the University of Wisconsin protocol has them on crutches and a boot and everything for several weeks afterwards, and like a 6 to 8 week rehab process. And I'm just, now that I'm starting on my own and like having to make these calls on my own, I'm finding I don't necessarily have like a great resource where I'm like, this is the one that I'm going to use for all of my PRPs. And similarly, even just deciding on, for example, with NeoA, a lot of the research is doing 3 subsequent injections 1 to 2 weeks apart versus just doing a single injection and stuff like that. Like, is there a good resource that you guys are using for this? And I guess just other than personal experience, is there somewhere that I should go to sort of model my protocols?
So really good questions. First comment is I think we all get it from everywhere. I think certainly I do. I shape a lot of my protocols based on personal experience, and a lot of those are, learning the hard way of what not to do. Meaning patients came back to me and told me about the bad thing that happened. And the third thing is the University of Wisconsin protocol is essentially an orthopedic surgery department protocol, as opposed to a sports medicine department or physio. It was the orthopedic surgery plus physiotherapy department. And a lot of them are just like quite restrictive. And so I think you just got to play it by ear and see, is this a more of a surgical patient or more of a sport med patient? And is there a surgeon involved? If there's a surgeon involved, that's very different than if it's you and the physio. So Patrick, Nathan, anybody else have any thoughts on that?
Unfortunately, I don't think there's a singular resource to devise protocols. It's an evolving process, and obviously Regenix in the US has led the way with a lot of things, but I think I'm operating based off of experience and also making judgment calls, especially when doing tendons. You look great when you're able to pull it off in one injection. However, sometimes when you look at that tendon, you know that it's going to need to be more. So there's a couple people in Toronto who are doing tendon injections on a monthly 3 injection basis. And then there's the osteoarthritis protocols that are 3 injections at 1 to 2 week intervals. But that seems to be best practice. I went to this Harvard Sports Medicine conference prior to COVID, and they did present a paper on the difference for knee arthritis with 1, 2 versus 3 injections. And the funny thing is I've never been able to find that paper ever again, but they were adamant that doing 1 treatment for knee OA was not all that effective. You had to do 2. If you did the second treatment, pain didn't reduce that much more. Pain did reduce more, but the third treatment wasn't for further pain reduction, but it was more about longevity of the treatment. So 2 treatments were better than 1, and 3 treatments did not improve pain, but improved the longevity of the actual PRP.
Nathan, it almost sounds like the Durlane study that said, if you top up a second one within 6 weeks or something, it extended the benefit. You know what I'm talking about there?
No, I don't, but it sounds about right, because that means that you got to buy more.
Yeah, I'm losing. I can't remember the paper, but Nolan, I think one thing I would say is, Nathan and I have wanted to do a PRP, and Trent have wanted to do a PRP course for quite some time, and it was never at the top of the priority list. So the fact that you're asking this question, the fact that we still have so many people on listening to this conversation, is yet another bit of positive reinforcement for me to say we need to put this near the top of the list. At a very minimum, make some sort of supraspinatus tendon. Here's a conservative approach, and here's an aggressive approach. And the aggressive approach would include 3 treatments and I don't know, a rotator cuff, repair brace, right? And a conservative approach would be like 1 with slightly tinged yellow PRP that measured at 0.6. And let them do whatever they want, right? And then you can just choose for your patient, is this a conservative patient or an aggressive patient or what, right? And you could mix and match. I think that's how I think about it in my mind. Am I feeling aggressive? Does the tendon looks like it needs it? And how's the patient feeling about this? and how's the physio feeling about this? And then we just kind of make our own way through it.
Great. One follow-up question to that, because I've had some conversations with some patients. I opened my clinic on October 3rd, so we're 3 weeks in today. And like when having these conversations, particularly about patellar and Achilles tendons and these weight-bearing tendons, and I talk about the Wisconsin protocol, and again, it's good to know that's from an ortho clinic. I'll forward that along. Have any of you guys ever actually seen a tendon rupture from any of these injections before? Because I think that's kind of what they're getting at when they're wanting to immobilize these guys and get them non-weight bearing, right? Is they're wanting to prevent the risk of tendon rupture. Has that ever happened to you with PRP? Because I feel like I've never really seen any reports on it in literature or anything to say like what the rate of it is, but it seems like the rate should be incredibly low, no?
What we know from, so I've never seen it, what we know from studies that look at tensile strength in the short period after an injection is that whether it's cortisone, lidocaine, or PRP, or even hyaluronic acid, tensile strength goes down for 72 hours at least after any injection. So therefore, I'm not saying booting people, but also can't send them back to their boot camp. Thoughts, Nathan?
I have personally never seen a tendon rupture as a result of that. I suppose if you completely destroyed or jabbed that tendon quite a bit, maybe you could. And I know that, there's a protective mechanism that's advocated for, but I always personally believed that the idea of putting somebody in a sling, et cetera, was to immobilize this space so that the PRP could sit in there and essentially allow it to do its work. Because I don't know if anyone's had any experience with this, but let's say like you do a lateral epicondyle, maybe you hit the intrasubstance portion of the tear, but sometimes that if a person dangles their arm very significantly afterwards, PRP will actually track down between the sinews of the tendon into the muscle tissues, and people can end up with significant swelling in their hand as a result of the PRP inflammatory process. So in my mind, immobilization of a weight-bearing tendon is a very good idea. I didn't think of it in terms of rupture though, so that might be my naivete, but I try to immobilize tendons after treatment as much as possible, as much as reasonably possible.
The decreased tendon strength papers that I'm talking about are largely animal models, where they expose the tendon to either lidocaine, cortisone, or PRP, or even hyaluronic acid. So the point is, anytime you chemicalize a tendon, it doesn't do so well when you put it under weight and see the strength, the Newtonian force to rupture. But yeah, I've never seen it. It's only a matter of time, though. It's only a matter of time. Andy, I prepared and published that "What's the Worst That Could Happen" video. I broke it into chunks and put it on the mentorship page. And again, just like Joe said, I don't know if like a biceps tendon ruptures, it probably wasn't the cortisone, it was probably the tendon.
Possibly. Yeah, Nolan, that the other thing I would think about with a weight-bearing tendon is that any tendon with PRP and that patients aren't thanking you for the first couple of days, it really hurts like a whore. So I think that having them off of their weight-bearing structures just from their own comfort perspective is useful, and because we can't use a heck of a lot, we can't use our regular NSAIDs to help them out. So, unless you want to use narcotics to help them, I think crutches are a much better idea initially anyhow.
And if you get really aggressive, you might as well put them under general anesthesia and wake them up in 3 days.
You could charge a lot for that in America. Dr. Ray, you got any thoughts? You're chilling out there on the coast, just listening to PRP talks. Have you got any questions or thoughts for us? You've been doing stuff like this a while, haven't you?
Just trying to unmute here. How's it going, Frank?
Good, man.
I just tuned in late, so I didn't want to say too much just in case it was covered. But in terms of my protocol for NEOA, I've been using HAs for probably 15 years. And PRP has really become a big part of my treatment plan. So my standard is 3 PRP treatments, usually a month apart, plus HA. And there's a few articles, I'm sure I don't have the references to share with people, but there is some good information out there now showing if you get HA. And if it's HA, I'll start with that, and then I'll do the PRPs afterwards. That's sort of my favorite and most recommended go-to. And I try not to let price alter that protocol. And then what else are you talking about? In terms of weight-bearing tendons, I've never seen a rupture with PRP. And I like to do like just little tiny multiple injections without ultrasound guidance on like an Achilles tendon or a patellar tendon. I find it's remarkable, even with one treatment, you can substantially change an athlete's symptoms and get them back to play like quickly. And again, it's, it hurts a little bit. So for the first 72 hours, I never immobilize them. I just tell them to be careful and be wise about it. Go home, put a little bit of ice on, and I think that usually takes care of it. I never boot them, and I haven't had a rupture. I don't know if that helps, but
yeah, I think it's valuable. I really appreciate that. Thank you. I'm reminded of a patient I saw recently. He went to the radiologist and he had something like 6 milliliters of PRP injected into his Achilles tendon. This was a 47-year-old male with mild tendinopathy. It was a pretty normal looking tendon. And yet the radiology protocol, unfortunately, involved slamming 6 mils come hell or high water into this poor tendon. I mean, if they did that to me, I'd be out for blood, right? And so the guy was literally psychologically traumatized from this. He's like, I don't think I can do PRP again if that's what I have to do. I felt so bad for him. So we did a dash of cortisone and it kind of marginally helped. And I said, look, I think the only thing left is we're going to have to do exercise. Right. So this is where I hope they've done physio ahead of time, but he got on heel drops, and, by about week 3 of the heel drops, he's like, my heel is feeling so much better. So again, I think it's important to, start with no needles first and then go up to, something else and then maybe PRP.
Totally agree. I mean, we're talking about injections, but the therapy and the joint rehabilitation, proprioception is a critical piece to everything we're doing. I won't inject people unless they're prepared to go and do the work with a good therapist.
For sure. Well, cool, everybody. Thanks so much. That's an hour and a half for a half-hour program. I love this, that everyone's keen on it. So thanks so much for staying to the very bitter end. And yeah, we'll have to get working on our PRP thing right after our emergency sideline medicine scanning. Hey, Andy. Thanks everybody for joining, and chat later.
Thanks for going late.
Thank you, Frank. Thank you.
See you, Riz. Thanks for joining, buddy.
Thanks, everyone. Goodbye.
I'll see you this weekend, Dr. Abelaran.
Thank you.
Goodbye.
Thank you all.